Hello, and welcome to the Out, Proud, and Proactive Gynecologic Cancer Risks, Screening, and Self-Advocacy for LGBTQIA plus people recording. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education at SHARE. For more information about our upcoming webinars, support groups, support lines, and more, please visit our website at sharecancersupport.org. Today, we are joined by Asante Facey, who we are so excited to have here. Al, before we begin, I'd like to hand it over to you to introduce yourself.
Of course, thank you. Hi, everyone. I'm Asante Facey. I use they and he pronouns. I'm a transmasculine physician assistant with expertise in treating people with gynecologic cancers, as well as providing LGBT affirming general gynecologic care. So I'm so happy to be partnering with Share to provide this webinar today. Just to set expectations, I want to start by talking about some LGBT general disparities before we get into the specifics for gynecologic cancer. So when you look at LGBT folks across the gamut, we have higher instances of mental illness, higher instances of housing and food insecurity, lower access to education, higher rates of substance use and abuse, particularly of tobacco products, and underreported incidences of intimate partner violence, and higher rates of all sexually transmitted infections, including HIV. And I share that kind of as an intro just to set the stage that LGBT folks in many areas have different outcomes and different risks. And this is really not inherent to who we are. It's reflective of the discrimination and bias that we experience in the world. And so when you think about how these experiences play into healthcare, negative, unsafe experiences simply make people less likely to go and take advantage of healthcare, right? So I have some examples here on the slide I want to highlight. When you look at medical trauma for LGBT folks, 20% of LGBT people of all identities avoid healthcare, period. They do not engage in any healthcare, even if they are sick, out of fear for discrimination and disrespect. 1 in 3 transgender people who do access healthcare report having to educate their providers just to get appropriate healthcare, and almost half report at least one negative experience within the last year. And negative experience could really be anything in the survey that I pulled this from. It could be being misgendered, being called the wrong name, but it also includes outright refusal of care and, feeling verbally or physically unsafe, or as the provider treats you roughly. And what that means is people just aren't going to get care. And when you look at cancer risks and outcomes, we need people to feel safe getting preventive care, having a provider they trust to decrease the risks of these things, right? So across the arrow, I just have some highlights I wanted to share about the decreased access to care for our community. As of January 2025, 20% of LGBT Americans lived in the 9 states where it is completely legal for care to be refused by a healthcare provider or facility because of who we are. Unfortunately, that number is likely to climb. There is less cancer screening. This comes from many different things, not having a provider you feel safe around, the gendered aspect of some cancer screening, especially I'll be hitting on that today. And as well as things like access to health insurance, access to employment that has time off, access to transportation to be able to get to this screening. And the outcome is obvious in that LGBT people experience more disparities in chronic disease, in long-term health conditions, and kind of across all other aspects of identity to mean race and ethnicity, socioeconomic status, things like that. LGBT folks report lower levels of healthiness, self-report lower levels of healthiness on surveys. And so now I'm going to transition into the real intention of this lecture, which is to talk about gynecologic cancers with an LGBT focus. I'm going to focus on the three most common types of gynecologic cancer: ovarian cancer, uterine cancer, and cervical cancer. First is ovarian cancer. So if you look on the photo, the ovaries are the white areas that I'm highlighting now. And ovarian cancer is an umbrella term for many types of cancer that can originate from the cells that make up the ovary. Another thing to note about ovarian cancer is often fallopian tube cancer, which are the fallopian tubes which connect basically the uterus to the ovary on both sides, and primary peritoneal cancer are often lumped into one thing and called ovarian cancer because they're treated and their symptoms are the same. The peritoneum is something that's a little bit hard to visualize, but essentially it's this fluid this lining that lines your abdomen and pelvis, kind of between the organs before the fat and muscle layers start. The prognosis and treatment of ovarian cancer can vary widely, and it's really determined by the type and the stage. The unfortunate reality for ovarian cancer is the vast majority are diagnosed at stage 3 or 4. And because of this, while it is a relatively rare disease, it's the 17 most common cancer in people assigned female at birth. It is the 5th most common leading cause of cancer death in people assigned female at birth, and it is also the most deadly gynecologic malignancy. So I'm going to talk more about the risk factors and symptoms on the next slides. I just want to take a moment to highlight an abbreviation I'm going to use moving forward, which is AFAB. AFAB is an abbreviation for assigned female at birth, which is really just the most inclusive way I can think of to refer to people of many different identities who likely have a uterus, fallopian tubes, and ovaries. So let's talk about the risk factors for ovarian cancer. So the top two on this slide are the biggest risk factors. One is age. The average age of diagnosis is 63. Ovarian cancer gets more common above 50 and after menopause. The other most impactful risk factor is your family history. So you have an increased risk if you have a close or first degree relative who had ovarian, breast, or colorectal cancer. First degree is something like a parent, a sibling. And then there are also genetic mutations like BRCA1 and BRCA2, which increase your risk for a number of cancers, but two of the biggest are breast, chest, and ovarian cancer. These mutations are more common in people of Eastern European or Ashkenazi Jewish backgrounds. The remaining risk factors are relative risk factor increases. They're not big increases, but they are things that I want to highlight when you consider your risk. So one is your own history of cancer. Having had breast, colorectal, or uterine cancer slightly increases your risk of developing ovarian cancer. Your reproductive history also influences your risks, primarily never having been pregnant or having been pregnant, but having your first full-term pregnancy over the age of 35. Hormone replacement also slightly impacts your ovarian cancer risk, primarily if it is long-term use and it is estrogen-only therapy. Endometriosis is also a rare cause of ovarian cancer. Endometriosis is a condition where the endometrial lining or the lining of your uterus kind of can grow outside of the uterus. It is rare, but it can become a rare type of ovarian cancer called clear cell. Having a higher body mass index is also linked to an increased risk of some types of ovarian cancer, not all. And smoking also increases your risk of mucinous ovarian cancer, which is a rare cell type. And so what are the symptoms of ovarian cancer? There are many to list, so I'll go over them briefly. Bloating, abdominal or pelvic pain, change in your bowel habits or your urinary habits, change in your menstruation, pain during intercourse, unexplained weight loss, or an increase in your abdominal girth. Like, for example, some folks, their weight won't change, but all of a sudden their belt buckle doesn't, they need to change a belt buckle. And also fatigue. And so these symptoms are tricky, right? And ovarian cancer is often called the silent killer. Um, and this is why folks often are diagnosed at stage 3 or 4, is it doesn't have a telltale symptom. But there are symptoms. The problem is these symptoms are vague and common, especially in people as they age after menopause, right? How many of you on today have felt bloated in the last week? And so this is why it's so important to have preventive care and a provider you feel comfortable calling when you're unsure if this something is serious. But the other thing I like to highlight is cancer symptoms are generally two things. They are persistent and they are progressive. So if you have, your body. If you eat something and feel bloated and it gets better, okay. But if nothing has changed in your diet or your bowel habits, but you're unusually bloated for 2 weeks, and especially if it's getting worse in nature, you want to make sure you get care. The other tip for ovarian cancer is if you think you are having a gastrointestinal issue, and your GI provider is not finding anything, always go to your gynecologist because sometimes these problems are coming from your reproductive anatomy. And so now I'm going to move on to uterine cancer. Uterine cancer, the uterus, I'm circling here on this picture. The uterus is the organ most people think of is what carries a pregnancy. And uterine cancer is an umbrella term for many different types of cancer that can start in the uterus. This uterine cancer is the most common gynecologic malignancy. It is the fourth most common cancer in AFAB people in the United States. And essentially, the types are broken into two types. Type 1 is the most common type. That is develops from your endometrium, which is the uterine lining that people would normally menstruate each month. Luckily, the vast majority of endometrial uterine cancers are diagnosed at stage 1 and have a very good prognosis. There is another subset of uterine cancer, which typically we lump into something called type 2. And these cell types are more aggressive. They are much less common, but they're more aggressive and they have a poorer prognosis. And something that's important in these is that they have a racial disparity in that they're significantly more common in Black patients and people of African descent. And the unfortunate reality for both types of uterine cancer is the incidence is rising, which I'll talk about, some theories as to why in the next slides. So let's think about the risk factors for uterine cancer. Again, the top two are the most impactful. One is age. Uterine cancer is most common in people over 50, most commonly happens in menopausal people. The other driver in uterine cancer is hormonal imbalances. What I think of when I think of what creates uterine cancer is a high estrogen level relative to a low progesterone level. And what these levels are can vary from person to person, but I'm talking about kind of relative in your own body, these levels. So what can drive high levels of estrogen? A big one is obesity. And this is one of the most impactful risk factors for uterine cancer. Fat cells make estrogen, and so that can contribute to a high estrogen environment. Hormone replacement therapy as well. I don't mean to make people fearful or hesitant for hormone replacement. I think there are many examples where it can be life-changing and safe. But whenever someone has a uterus and takes hormone replacement, it's important that you have both estrogen and progesterone. If you only take estrogen hormone replacement, you're kind of creating an environment in your body that can easily develop into uterine cancer. And the other hormonal imbalance is polycystic ovarian syndrome, or PCOS. PCOS is a tricky syndrome. I don't have enough time to get into detail to it today, but essentially it's a hormonal imbalance that leads people to not ovulate, to often not have regular periods. And what happens with that is that they have high estrogen. Right before you menstruate, you have a surge of progesterone that, triggers the whole menstrual cascade, but in this example helps protect from like this high estrogen environment. And that's why, there is no cure for PCOS. It's something that someone just has in their body. There are ways to mitigate the hormones, but it's important for you to know that we do have to regulate bleeding or protect the uterus with progesterone in some way. And finally, family history again is an increase in your risk, not huge, but if you have close relatives who have had uterine, ovarian, or colon cancer, also never having been pregnant is a risk factor, and use of tamoxifen. So again, I don't mean to scare people. Tamoxifen is a medicine that is usually used to prevent recurrence of breast or chest cancer. It is a very important and safe medication, but it does have a small increase in the risk of uterine cancer. So if you're on this medicine, it's important that one, you report any abnormal bleeding, but also you have a gynecologist you trust and see regularly, even when you're feeling well. And so let's talk about symptoms. The most common symptom, the bread and butter example of my practice with uterine cancer is a person is in menopause, they haven't had bleeding for, let's say, 3 years, and then they call me up and say, I've been having bleeding like a period for 4 days. That is not normal and you should always get care. If you are not in menopause yet, bleeding between periods, bleeding randomly, unpredictable bleeding is a symptom. That is by far the most common. We also see pelvic pain, unusual vaginal discharge, which is usually watery or blood tinged or pink, pain during intercourse, and unexplained weight loss. And then my take home point, bleeding after menopause is never normal. Most of the time, it is not uterine cancer, but it can be. So please, always seek care if you have those symptoms. And now cervical cancer. So cervical cancer is, again, a kind of a big term for many different cell types of cancer that can originate from the cervix. The cervix is at the very bottom of the uterus. The most common type of cervical cancer is squamous cell carcinoma, and the majority of cervical cancers are caused by human papillomavirus or HPV. When you think about cervical cancer, the incidence varies widely depending on whether you're in a well-resourced or under-resourced country. And that's because we have a screening test. This is the only cancer I'm going to talk about today that has a screening test, right? We have a PAP and HPV test that folks should get. And because of that, you see differences in how common it is. When you look worldwide, it is the fourth most common cancer in AFAB people. But in America, it's relatively rare and the incidence is decreasing. Cervical cancer does generally happen when you're younger. The peak incidence is like 35 to 44. I want to highlight here, I'm not going to go too into detail about cervical cancer screening and HPV and the risk in the LGBT community, because Cher already has a great resource that you can look back to. Dr. Quinn did a webinar focusing just on HPV cervical cancer screening in LGBT folks, so please check that out. But what are the risk factors for cervical cancer? When I think of the risk factors, I think of it in two buckets, right? One is, what is your risk of HPV? And have you gotten your pap test, right? So I'll start at the bottom since it's a little bit easier. Cervical cancer has a screening test, and we understand the progression of a normal cervix to a cervix with cancer. There are these precancerous changes, which you may have heard before. It's often called cervical dysplasia, that can be treated if you are getting regular screening pap tests when you're feeling well. So one of the biggest risk factors is lack of adequate screening, right? If you don't have these tests, you don't know that you are at risk for cancer. You just know when you have symptoms of the cancer. And now let's talk about HPV, right? So HPV is tricky. It is a very common virus. It is a sexually transmitted virus, but the vast majority of people have it. We don't have a good test to know the numbers, but most people estimate between 50 and 90% of people have at least one strain of HPV. HPV, there are many different types of strains that have different risks, and there also is a vaccine for it. So one of the risk factors I put up here is, have you had a vaccination for HPV? Um, Another thing I put up here is sexual exposure, right? So your sexual practices can influence your HPV risk in that I kind of always advise patients, every sexual partner probably has a strain of HPV just statistically. And so you are putting yourself at risk for more infection. So I kind of think of it in two ways when I think about, sexual exposure and HPV, the number of new partners, as well as the age that you initiate sexual activity. And that's because it's not really HPV itself that's the problem, because I'm telling you almost everyone has it, right? Or at least half of people have it. It's persistence of HPV that drives these cells to change from normal to precancer to cancer. And so the next two things really highlight activities that or issues that can make the HPV more persistent in your system. HPV is a smart virus. Just to set expectations a little bit, it's one of those viruses where you're exposed to it, it's active. Um, average for an average person, it's active about 2 years and then it becomes dormant. You still have HPV, but it's not active and it's not causing problems. But if you smoke tobacco, if you are exposed to tobacco, you're much more likely to have the HPV persist and be active for a longer amount of time. Also, your immune system plays a role in this, right? So to change the virus from active to dormant, your immune system does that. So, if you're a person living with HIV, if you're immunocompromised due to a health condition or a medication you take, that can lead to increased HPV persistence, which can increase your risk. And so, not to belabor my point, there is a screening test for cervical cancer. Get it on time, mark your calendar. And these are symptoms we've heard before, but when you think about cervical cancer, again, these are, I would say, the most common are abnormal vaginal bleeding, especially in situations where you're bleeding after the cervix is touched, right? So that might be, after, vaginal penetration. That might be after a pelvic ultrasound, after a speculum exam. You also can see unusual vaginal discharge, which is usually watery or blood tinged. What's tricky about discharge that I just want to highlight is there is no normal discharge. It's one of those things where know yourself, know your body, know what is normal for you if things fluctuate during the cycle, and just be aware if things change. You will know this more than anyone. Again, discharge can change and does change, but you want to look for something persistent and that is abnormal for you. And you're never wrong to go to someone and ask and have them tell you it's nothing, right? The other take home point of this is cervical dysplasia or precancer has no symptoms. You will not know until you won't have any symptoms until you have a cancer. And so this is why preventive care is so important. So now I'm going to take a few minutes just to kind of talk about everything I presented and how it impacts specifically, our community. So when I think about GYN cancer and LGBT folks, one thing I think about is lack of knowledge. And that's because the LGBT identity is invisible unless it is recorded, right? Think 30 years ago when they started to ask people their race and ethnicity data. That was important for the knowledge we have now about differences in prognosis, differences in treatment for people based on their racial makeup. So we must collect sexual orientation and gender identity data, which I will abbreviate to SOGI from now on because it's easier. On the side of my screen, the graphic is basically just an example of what collecting SOGI data looks like. You go to your appointment, you're filling out 10 pages of paper. My hope would be one of these pages is asking you your gender identity, your sex assigned at birth, your sexuality. That is what will give us the knowledge, 10 years down the line about exact risks, exact differences in outcome based on people's identity. This is particularly important when you think about cancer care for people on gender affirming hormonal treatment. Um, don't take me the wrong way. Gender affirming hormonal medication is absolutely safe and studied and has been around for a long time. I'm not talking about the safety of that. I'm talking about how could how could being on gender affirming hormonal treatment impact having a hormonally responsive cancer? Those questions are hard to answer, and we really need to get better at collecting SOGI data to be able to know the answer. And then the next thing I want to highlight is the limitations of having safe, accessible, comfortable GYN care when you're an LGBT person, right? So I just have some examples that came to mind on the slide, which is, you go to the GYN, you're doing everything right. Are you sexually active? You say yes. And then they look at you like, and you're not using contraception, right? And that's difficult. They assume that you're, sexually active with someone who could get you pregnant, or you're going to an important appointment. Maybe you're nervous or getting results that could be, very serious. And you bring your partner with you, and they're like, "Oh, you brought your sister," And this is tricky and it's invalidating. And I think what's so important in healthcare is being seen and heard as a person, right? And so healthcare needs to get better about opening up to people who are different and lack of assumptions. Um, the other thing is the gendered aspect, right? So I particularly for me, but for lots of trans and gender expansive folks, right? Maybe getting your screening pap test involves going to the women's health center, putting on a pink gown, there's only a women's bathroom because who else would even be there? And it's uncomfortable and it's not safe. And these are barriers we have to fight just to get in the door. And finally, I always like to highlight the lack of trauma-informed care. Something that's very important to my practice is the assumption that anyone coming in, especially assigned female at birth, has experienced, coercive touch or sexual assault. And that particularly comes up when we're talking about doing pelvic exams and how invasive they are. And that's a lecture for another day, but look, if you're someone who's had that experience, look up ways to support yourself. One of the biggest ones I would say is bring someone with you who can help make sure you feel empowered. And then when we think about cancers generally, somewhere between 20 and 50% of cancers are caused by what is called a modifiable risk factor. So a modifiable risk factor is something you could, in theory, change about yourself. Non-modifiable risk factors are like your DNA, your genetics. You cannot change that. And there are certain modifiable risk factors that those of us in the LGBT community are more likely to have. And so that's really what I've highlighted here. AFAB queer people are more likely to be obese. And that, as I've said before, it significantly increases your risk of uterine cancer and also some types of ovarian cancer. Not specific to GYN cancer, but alcohol intake, use and abuse. LGBT people, particularly AFAB, bisexual people, are more likely to be heavy drinkers. Um, all LGBT identities are more likely to be exposed to tobacco, which has a significant increase in your cervical cancer risk. And then when you look at pregnancy and breast and chest feeding, right? So I think this is a little tricky when you consider it like such a modifiable risk factor, because some people simply don't desire to do those things, but they impact gynecologic and also breast chest cancer risks. And so these are things that our community may not be aware of that impacts our outcomes. If I haven't said it yet, I will say it one more time. The most important thing about cancer is that you have preventive care to keep you healthy and keep you up to date in your screening before you have a cancer. So you need a gynecologist or a GYN provider, a family medicine provider, someone you feel safe with, and see them every year. See them after menopause, see them if you're feeling well, see them if you have no interest in carrying a pregnancy. And also, lots of AFAB people, especially younger, skip having a primary care doctor. And that's also really important. Um, so what can you do? I've kind of jumped the gun a little bit, but you need providers you can trust and you need to see them. I talk more about resources for safe and affirming providers on the next slide. The next thing is, LGBT people don't always feel safe and welcome by the healthcare community, and we have to empower ourselves. We have to know the risks, we have to know the symptoms, and we have to get rid of shame and talk about these things with your friends, your family, your community. Modify your risk factors whenever possible. Bring a support person with you to advocate at visits. This is something I think is really important in healthcare. If you have a visit where you're nervous, if you have a provider that makes you feel rushed, if there's something you're afraid might happen at a visit, tap into your community and ask someone to come with you and advocate for you. Say, please take notes because I'm feeling really anxious and may not hear that. Please make sure they do this, they don't do that. Don't be afraid to ask for help to keep yourself safe. And disclose SOGI information when it's safe. I think particularly right now, it's hard to advocate people to be visible as an LGBT person, but when you are safe and have the privilege to do so, please do, because that will really expedite the science for the community in 20 to 30 years. And so talking about finding an affirming provider, my two best resources are GLMA, which is a healthcare organization for providers who care for LGBT folks, put together the LGBTQ plus healthcare directory. That has access to all different types of providers, physical therapists, massage therapists, anything you can think of that are welcoming and safe. The National LGBT Cancer Network put together a provider database that is specific for cancer screening and cancer treatment that you can access for resources. And finally, props to Share, who is growing their LGBT patient-facing resources and education. So please also check them out. Thank you.
Thank you, Al, so much for that incredibly important and informative presentation. We really appreciate you joining us today.
Of course, really my pleasure. Thank you.